In this video, we're going to talk about the most common reasons people struggle with dilation after bottom surgery. I'm going to broadly classify them into two different groups, although there can be a lot of overlap, and I will explain. My name is Dr. Saib Gallagher. I'm a plastic and reconstructive surgeon based here in Miami, Florida. And for the past 10 years, my practice has been heavily focused on bottom surgery, especially for trans feminine patients. And we do vaginoplasty, zero depth surgery. But I'm going to talk about a very common issue people can have after vaginoplasty, and that is not being able to dilate or losing depth or girth and basically struggling with painful dilation, that sort of thing. So let's get into it. So when I think of difficulty dilating, there's really two broad categories I think about. And the first thing is that the patient has difficulty with the pelvic floor. They have a sensitive pelvic floor, a tight pelvic floor. We don't fully understand why, but some patients, when we dilate past that pelvic floor, we create the vagina past that pelvic floor, which is a wall of muscle. It can cause pain in some patients and difficulty relaxing that muscle and letting it open up. If a patient has difficulty from the very get-go from dilation, this is probably what is going on. If, however, a patient is dilating well from the get-go, tolerating it well, doing it several times a day as they should initially, and then with time, usually about 2 or 3 months, they're beginning to find it more and more difficult to dilate. There can be pain associated with it, sometimes bleeding, and they may be diagnosed with what's called granulation tissue, which is this soft, bright red tissue, usually around the entrance of the vagina. And this is usually caused by scar tissue. So this is a different type of problem when where the patient grows scar tissue around the entrance of the vagina, making dilation painful and in some cases pretty impossible to do. To confuse things further, there's often a lot of overlap, and like my patient on Friday, for example, she had both components and they lend to each other because obviously if you have scar tissue on the outside, dilation is going to cause pain. Pain will tighten up your pelvic floor and it becomes a vicious cycle. A lot of patients obviously start disliking dilation because it's frustrating and it's causing pain, and so they're going to dilate less, which of course means that things are going to narrow in sooner. So what can we do about these problems? First of all, it's very typical that patients reach out months after having stopped dilation, and we're kind of in a bind at that point because usually we're going to need at least a surgery to open things up, and that surgery is risky because there's a lot of scar tissue down there, and as you know, there's pretty limited real estate down there. We're right next to the rectum, so it means when we try to open things up again, risks of a rectal injury and needing a colostomy bag are even higher. So you don't want to sit on this if you're not, no pun intended, but if you're not able to dilate, it's better to reach out to your surgeon sooner rather than later. Sometimes it can be a technique issue, and they can do different things like coach you through dilation, or better yet, refer you to a pelvic floor physical therapist who can help you with techniques of dilation. Sometimes if it's minor scar tissue, this can be dealt with in the office, and earlier the better in this circumstance. If you're in that first category of patients I talked about where the pelvic floor is very sensitive and kind of from day one we're struggling with dilation, then in that case it is really important to get you in with a pelvic floor physical therapist as soon as possible. Pelvic floor physical therapists tend to have a whole PhD in how to deal with the pelvic floor. What I'm saying is they usually know a lot better than your surgeon techniques, relaxation techniques that can train your body to control that pelvic floor better and to dilate a lot better. So they're an amazing resource. I find even if they've never worked with a trans feminine patient, they know the anatomy down there and can be an enormous help. So typically what we're going to want to do if a patient comes back, and like I said, it's not unusual the patients come back and it's been a few months since they've dilated, ultimately we're going to want to do an exam, and so we're going to see what we're left with in terms of width and depth of the canal, and usually we're going to want to do a surgery to open things up again. I can do a lot more in the operating room when you're relaxed and asleep than I can do in the office with you awake, but some patients, for example, may not be able to afford the downtime or the cost of a second surgery, and so sometimes we'll try that as a salvage procedure. Now, as you know, with bottom surgery, vaginoplasty, it is a two-part surgery, so there are certain maneuvers we can't do at the first surgery, usually got to do with aesthetics, like for example, to bring the labia majora together at the front. And so we will always plan to do surgery number 2, and you have to keep that in mind. What we're often able to do in patients who are having difficulty dilating is go ahead and do the labiaplasty. In most cases, do it a little bit early, combine that into opening up the vagina again and doing the labiaplasty, helping with the aesthetics. So ultimately, hopefully, that patient won't need an extra surgery in order to fix this. So the take home is, don't be a stranger, especially if you're having difficulties with dilating. Early intervention is better. A lot of my patients fly in for surgery, but sometimes there's even things we can do remotely, like connecting you to a pelvic floor physical therapist. And sometimes we get really lucky, and that's all that the patient needs in order to continue dilating well. Otherwise, especially if it's scar tissue, like I said, we may have to do another procedure, and typically, thankfully, that can be combined in at the time of the labiaplasty.